I call upon Dr. Ravi Trehan for customized incision cataract surgery in SICS.
At the outset, I'd like to give thanks to ISM6 for giving me opportunity to speak on this topic, customized incision cataract surgery. As we know, there are two main techniques of cataract surgery, SICS as well as phaco. And when we broadly see what is SICS, what is phaco, if you want to go for, generally what our trend is, if you want to go for quality, then you go for phaco. And if you need large, huge surgeries in camps, you go for SICS, means quantity. And the main problem is, or main drawback which I and all of us feel is astigmatism. If we reduce the astigmatism from SICS, then this will become customized incision cataract surgery. SIA is a very well-known factor affecting each and everything. Total results are affected with this. But when this SIA we use by our own means surgically corrected astigmatism, then this will give help to us and our results are really better. A very small equation which I wrote. In SICS, if we deduct SIA, the results will be equal to phaco. And if in phaco, we add the results of surgically corrected astigmatism, results are even better, and that is CICS, that is customized incision cataract surgery. I know in basic courses it was taught that how SICS was done and what. I'll just give some tips for conversion to SICS. Here, my aim is not to reduce astigmatism. I want to use this astigmatism for my benefits. So, first topic is site of incision. Here, three incidence is given. In each case, one diopter pre-op astigmatism is 180 degree, means ATR. In first, the incision is given temporally, in second, superiorly, and then oblique. There are different effects. In first case, astigmatism reduced, axis will remain same. In second, astigmatism will increase. And in third, axis as well as astigmatism is changed. So we can use these data. Size of incision. In customized incision, we have to modify our incision according to different points, that is grade of nuclear sclerosis, which type of IOL we are going to implant, removal of nucleus in toto or divide, and what about preoperative astigmatisms. Every time you have to mark the incision, always do it sitting posture. If you do in lying down, then the problem will be there. Shape of incision is straight, curve, and chevron. Beginners must go for straight and gradually move to chevron. But if you want to correct large astigmatism, you have to go for straight. And if you want to induce very less astigmatism, you have to go for chevron. One another technique, if nucleus is big, you want to remove in toto, straight. This is my usual routine, straight incision with radial cuts, scleral pockets, and then inner entry. Second option, what I have given, 6 millimeter straight incision with radial cuts, again scleral pockets and entry. With this, I have specifically mentioned this 6 millimeter with radial cuts because any kind of nigra can be removed from this. Depth, it is 50% should be must. If it is less, then chance of buttonholing is there. But if it is more, chances of fish mouthing is there. And in both the cases, control of astigmatism is not in your hands. About size of tunnel, corneal part of tunnel should be more than 1.5 millimeter. One more important point, entry in anterior chamber and extension. I have different positions. Number one, 2.8 millimeter keratome entry, then extension with same. Here, I filled the visco in AC and then extension. Here, difference is that extension with 5.5 millimeter. Hypotensive, normotensive, and hypertensive, These eyes will produce or correct different amount of astigmatism. And what my choice is, fill the visco AC from the side port, 2.8 millimeter keratometry extension with 5.5. And one important point, in any case, extension should not cross the limbus. Fresh and sharp blades, each and every speaker used to say, but I mentioning you have to customize your blades. Number of types of blades are available from 20 rupees to 800, 900 rupees crescent blade is available. One should try each and every one and then see which one suits him. Size of the incision should be pre-planned according to slit lamp examination and as well as keratometry. But if we have to extend the incision in between, then astigmatism will not be under our control and there should not be any struggle in tunnel during lens delivery. Some take-home message I would like to give: temporal, superiotemporal, and superior incisions. These induce different amount of astigmatism even with same size. And to start with, if you are not able to customize, at least start doing surgery with temporal incisions. Some SIA calculators are available online and free. Dr. Hill and Dr. Saurabh Sahani from Delhi use these calculators. You have to put K1, K2 readings pre-op as well as post-op, and these will give very good results. You have to customize your SIA and use that SIA or SCA for the benefit of patients. Thank you.
Thank you, Dr. Ravi Trehan, for an excellent talk.